Good afternoon and welcome to HCRF Talks COVID with Dr. Platanias. This is session 24 with Dr. Platanias, and we're so thankful to have him back to not only address the latest about COVID, but also cancer as the fight to make progress in both continues, especially during these trying times. I also want to thank everyone in the foundation and Eleni. All of us are here together because we are concerned about COVID, but we continue to care about cancer patients. Caring about cancer patients is so important. As I mentioned before, in the Lancet Journal, which is a high impact scientific journal, it's been estimated that there's been a 10 to 15% increase in cancer diagnoses during COVID times. And all of us are here today because we want to make a difference. We also have a special guest joining us today, Dr. Maha Hussain. Thank you so much for being here. And
Thank you.
Dr. Platanias is going to tell us about the significant advances in cancer research that she has made and how she plays a leading role at the Lurie Cancer Center.
Yeah, Dr. Hussain is the deputy director in the Cancer Center. It's the number 2. And she joined the Cancer Center in 2016 from the University of Michigan. She has an extremely distinguished career. She's one of the leading figures in the world on the treatment of prostate cancer. Just the last 2 years, her work resulted in 2 FDA approvals, publications in the New England Journal of Medicine with her as the lead author, something extremely, the most prestigious medical journal. So she has a remarkable presence in the field and had huge impact in the treatments for prostate cancer. In fact, the last treatment that got FDA approval from Maha's work was the first time that it was driven by gene molecularly driven treatment for prostate cancer. So she plays a very important role in the Cancer Center overseeing clinical research. And it is a pleasure to have her here today.
Thank you so much, Dr. Platanias, and everyone. It's my pleasure and privilege to be part of the team.
Yeah.
Dr. Hussain, can you tell us a little bit about what are the biggest steps? I know Dr. Platanias mentioned the molecular identification of markers for prostate. What are the biggest advances that have happened for prostate cancer?
So I think in the last, probably I want to say, give and take 10 years, there's been really a huge progress in the disease. And every year we go forward, there's been more impact in the area. So the progress began, I want to say, if I want to go to really where the doors opened in terms of trying to impact the deadly phase of the disease, actually began in 2004, when the first drug ever to demonstrate an overall survival advantage, so prolonging life in the context of patients who are destined to die, end-stage disease, was approved by the FDA. When that drug was approved, drug docetaxel, which I was also involved in some of the work that was done with it, that really opened up the door for more investment, because up until then, the feeling was that prostate cancer is a very resistant disease and there's not much can be done, and hormone treatment pretty much it. And a lot of drugs were tested and really they did not lead to any advancement. So fast forward, we've seen really many FDA approvals moving on. And I think one of probably the biggest benchmark that occurred is demonstrating that effective oral agents, hormonal agents, can actually prolong life even in patients who have progressed on chemotherapy. And so all of these drugs were moved into earlier phases of the disease, and we began seeing multiple, again, data indicating improvements. And so I can make you a list of all the drugs that have just gotten approved in the last 10 years, drugs like docetaxel, as I mentioned prior to that, abiraterone with prednisone, enzalutamide, apalutamide, darolutamide, cabazitaxel, and most recently olaparib, and another PARP inhibitor. Now, up until recently, prostate cancer has been really a maze. It was very difficult to sort out. We know the genomics of prostate cancer, but there's not been any treatments that are specifically targeting any of the genomic alterations. I was part of the Stand Up to the Cancer team several years ago that identified the fact that the BRCA and BRCA-like genes are actually prevalent and important in the prostate cancer biology, which then led to a series of clinical trials. And the end result was that, in fact, now we have drugs approved specifically based on the genetic makeup of the cancer. And so I think we've come a long way.
That's really surprising, because aren't those genes predominantly found for breast cancer? So that's
Correct.
amazing.
Correct. Yeah. And I think one of the things that I think it's important to recognize is that we have the identification of these genes occurred in breast cancer, ovarian cancer, then most recently in pancreatic cancer, but prostate was sort of lagged behind other cancers. And so at this moment, I think we're catching up, so to speak. And the PARP inhibitors right now have gotten approved in prostate cancer. Several of them are there's a whole list of them, and I'm happy to share slides with you for the audience if it's helpful. But the point here is there is a lot of work going on. A lot of these drugs are being moved into earlier phases of the disease. Another area that is novel, I think, and I am expecting that we would hear more news about it, is the whole issue of better imaging. So as you know, a lot of patients have surgery or radiation, and then their PSA goes down to undetectable range, and little time later, few years or few months, the PSA starts to go up, and we do scans and we see nothing. And the current scans are not sensitive enough. As I tell patients, a sphere this big of about 1 cubic centimeter can have actually 1 billion cancer cells. And so consequently, if you have a lot less cancer cells, not 1 billion, it's not going to show up on the scans necessarily. So now we have actually smarter technologies that are helpful for imaging, which I think will end up moving a lot of these drugs that we are evaluating in the current space into even earlier stages of the disease, where I think we will begin to see even the hope is for a cure there. So the PSMA, for example, is one, and that's being looked at by the FDA shortly. And then PSMA tagged treatment with lutetium and a drug that is, so radiopharmaceutical targeting a PSMA in the body is another set of data that is reportedly positive, should be presented, we expect, at our upcoming meeting at ASCO. And the anticipation, again, is that it will be moving into FDA review. So I think there has been really a lot of success in the past few years.
That's very encouraging that there's all these promising treatments, because I think the devastation with prostate comes that the metastasis later on. So that's really great. Does anyone have any questions?
One thing I want to maybe highlight, and yes, prostate cancer is an aggressive disease, and no cancer is good, to be clear. The best thing is not to have cancer. One thing about prostate cancer that I think is interesting, and it's an observation that we reported several years ago, is that it is compatible with long living. Now, clearly, no one wants to live with cancer for a long time, but in fact, if we cannot cure, and if we cannot prolong, the best thing that we can do right now is prolong life. And from a study that was an international trial that I ran several years ago, was run by it's an NCI-funded clinical trial, ran through the cooperative group SWOG and other cooperative groups, where we looked at patients both in the US, Canada, and Europe, and where the study was looking at the schedule of hormone treatment. And what was interesting, long before we have all of these life-prolonging drugs, men with metastatic prostate cancer, metastatic but hormone sensitive, as we call it, had about 17% of them were alive at 10 years. That actually is remarkable in that there is a chronic element to it. And certainly as we begin to improve the treatments for advanced disease and move them into earlier phases of the disease, I do think that we are likely to lead to reducing the death rate from prostate cancer and converting it more into a chronic disease when it's spread, as opposed to an imminently deadly disease.
Dr. Hussain, can I ask, we have mammograms for breast cancer patients. So how reliable is PSA testing for males?
Well, the PSA is not cancer specific. PSA is prostate specific. And there are several guidelines and different workups and strategies that are there. I would encourage all patients to discuss with their doctors the opportunity to have their PSA evaluated. The guidelines keep shifting on a regular basis. One thing I want to point out, and only because I do end up seeing in my practice younger men with disease. My youngest patient, when I moved to Chicago, actually the first year, was a 37-year-old. And we always were taught that prostate cancer is a disease of older men. Now, in my practice, I have men in their 40s and in their early 50s with advanced disease. The critical part is this: if someone has symptoms, they need to be evaluated. It doesn't matter what the PSA is. The critical part is if there are symptoms that are to be evaluated. If the doctors do a rectal exam on them and they feel a nodule or a mass or a kind of harder prostate, that needs to be evaluated. And certainly if the PSA was elevated, then the guidance would be in the context of just random annual evaluation. So no symptoms, no abnormalities on physical exam, but the PSA is elevated. And the recommendation would be is to have a repeat. And then if it's elevated again, then to undergo special MRI. So I would say that is when a referral to urologist becomes important.
Doctor, first of all, thank you so much for joining us. We're told that most of us men, if we live long enough, will get prostate cancer. So I guess the key is to, live long enough, and hopefully that's 100 or more. So I'd be really interested in a little bit more detail on, what's recommended. We hear about self-examinations for women, but what sort of examinations, testing, screening should men do? But before you even answer that, you work directly under one of the greatest people, doctors, researchers, and leaders in the world. And could you just tell us a little bit how it is to work under Dr. Platanias and how inspiring he is to the work that you do?
Well, it's been really a pleasure. Dr. Platanias and I met a few years back. Our paths had not crossed before previously because of the areas where we work in. Although I should say, in my young adulthood, I wanted to be a hematologist and work with leukemias and lymphomas, and then changed my mind after rotating through my training at the time. I think.
What changed your mind?
Some of it had to do with the fact that I started working in a VA hospital. And this was the Allen Park VA, in one of the oldest VA hospitals in the nation, actually built before World War II. And it was my understanding, it was the land was actually Ford land given to the Veterans Administration to build the VA. And what was amazing to me then is that by sheer number, you saw so many people with solid tumors, lung cancer, head and neck cancer, so smoking related cancers, prostate cancer. And really our hands were tied. There was not much to do for them. And I had never really realized it that much. Is different than when you're working in a structure when you see different population, a different, males, females, younger, older, things like that. By default, the VA was mostly men, mostly older men. And so it felt like you needed to do something to help the people there. And that's kind of when my passion for head and neck cancer actually, and prostate, because literally at the time, nobody wanted to do anything with it. And there were some emerging data on chemotherapy in head and neck cancer, obviously the hormone therapy situation in prostate cancer, the desire to actually do more work there. And that's kind of what got me into the field there. So I stayed with solid tumors. And then as I'm sure you are aware, the expansion in research, it's impossible to be knowledgeable in just about every single thing. I mean, to be fair, as much as I think I'm a genius, but it's not something.
The only one that can do that is Dr. Platanias.
Oh, yes, yes, just him. Yeah. And so, so fast forward, Dr. Platanias and I met, and then one day I got a surprising call, and he said, you know, we're looking at potential individuals. Would you be interested? And I said, well, I could come. And we loved Chicago because obviously it's love. It's lovely city. It's fun and great. But I said I'd come in the winter time because we always thought in Michigan that Chicago weather was worse. And to my surprise, actually, December we had snow and Chicago had no snow. Then came in for a second time and I said, well, I'll come in February because I want to see how bad it is. And there was no snow and we were covered in snow in Ann Arbor. But I think I'm joking about all this. I do think the opportunity was great. There was a great team. The strength of the healthcare system, the strength of the university, the strength of the cancer center, the team that Dr. Platanias has built was very exciting. And then in the business I'm in, obviously we're not necessarily, you know, in clinical research, you want to partner with a variety of people because obviously we want to do multiple clinical trials and research projects. This is different than, say, if you're in the lab and you're supposed to really focus on certain areas. So in the business I'm in, clearly diversity in terms of the research that's going on is exciting. And so that was really attractive. And I have to say, I am delighted by the move that I made. And I think we have a fantastic team. And the success is really Dr. Platanias' leadership and the talent of the team.
That was a great answer. So getting into now your area, talking about screening and testing and early diagnosis.
Sure.
Could you just give us a little bit on that?
I think, so I want to point out that there are several guidelines that are going on. However, the guidelines got adjusted. And so the most recent would be the American Urologic Association guidelines. And the general recommendation is that there is recommendation against what we call PSA screening or early detection in men under the age of 40. The panel conclusion was they did not recommend routine screening in those patients between 40 and 54 at average risk. Having said that, any patient who has a strong family history, and they are younger, then basically this is where the conversation with their doctor should occur about the merits of doing a PSA test versus not. One thing I want to point out, as I mentioned earlier, is that if a patient has symptoms or if the doctor did as part of the annual exam, a rectal examination, and they identified a mass, that's a different story. So that's not what we call early detection. For the men between 55 and 69, basically, I think there has to be a shared decision in terms of evaluation. And as a physician who sits on the other side of the aisle, I don't see these patients first, I see them after the fact. My recommendation is that patients should, or individuals, men should discuss with their doctors the merits of it and proceed with it. And one of the things that are important based on the level of the PSA and so on, and I'm happy to provide you tables to look, for your audience to look at, is that if in fact the exams are normal, the PSA is normal, all of that would be fine, then the actual recommendation is to space out the screening intervals for 2 years or more. And there are certain tables to be followed. And then there are, again, as I mentioned, if the PSA is elevated, then in that case, a repeat needs to be done. And if that is confirmed, then definitely evaluation should be pursued. Now, the AUA panel guidelines did not seem to recommend routine PSA screening in men age 70 and older. So when I talk about screening or early detection, I am talking about people who have no symptoms. Or anybody who actually has a shorter life expectancy. So unlike other cancers, prostate cancer, even when it's diagnosed, is compatible with normal living. And in fact, in one of the trials, again, that I ran, the vast majority of men who end up dying, even though they had high-risk prostate cancer, end up dying from other causes and not prostate cancer. So a 70-year-old or older, or somebody who doesn't have a longer life expectancy, then that's not something that's recommended. Again, there are men who are older, but you expect them to live, another 10 years or 15 years. I don't think, again, it's wrong to do it. And this is where I would say the critical to actually have a shared decision with the patient.
And one more thing on before we get into the treatments, what are the symptoms that men should recognize as alerting them to go see the doctor?
Well, I think the first thing I would say, the most ideal situation is for men to actually go on a regular basis through annual evaluation for all their health. And this is what I do myself. And that's what I tell my family to do. And same thing goes with my, as I say, kids to do. And so every adult should have an annual evaluation. Now, again, there are general guidelines looking at different things, cardiovascular issues, cholesterol issues, things like that. For women, obviously, breast cancer and mammograms. For men would be the issue with the prostate cancer, colon cancer, early detection, and things of that sort. And so that I think would be the first step. The second step would be is if a doctor does not, let's say, offer an individual the PSA check or the rectal exam check, I think the individual should.
No man is going to request that.
Of course, it's not something that is fun to do, but I'll tell you, women go through also mammograms and it's not fun. And we go through all kinds of cervical cancer detection and that's not fun.
But that's why
it's not about
babies, because you're a lot tougher than men. We can't handle
you
it.
guys are tough. You just have to be, and I will tell you this, and if the audience is also the significant others, I would say, if you are the daughter, the wife, the girlfriend, the friend, the whatever of a man, make him go do it. I think that's healthier and it's much better. Anytime you want to pick up cancer, you want to pick it up earlier, not later, because that's really where the chance of cure is there.
And one last question, and then I'll shut up, which is, I, for one, am interested in the listing of agents, but can you tell us a little bit about, the overall treatment menu and when they may go to, for example, in addition to agents, which thank God there's been a lot of progress thanks to you on that, but there's radiation, there's radioactive seeds, there's the Da Vinci, which I think was named after Leonardo, and then there's surgery. But what sort of circumstances?
So I think, yeah, so basically there are several shades of gray when we're talking about early stage disease. There are patients who have a low Gleason grade, which is looking at under the microscope, the cancer is very, very mellow. They have no symptoms, the PSA is low, the evaluation is done thoroughly. Then these men have the option of what we call active surveillance. And what that means is essentially ongoing evaluation. The flip side would be is when we're talking about patients who have a higher risk, so what we call intermediate risk or higher risk prostate cancer, then that's really where the recommendation is for treatment. I want to highlight one thing. Just because somebody has a low risk prostate cancer does not mean that they could not opt for a treatment. And sometimes I would say not every, there's like sort of a bell-shaped curve. There are men who will go on for a while with nothing changing, and they end up living and dying from something else. And there are situations where the opposite, the cancer actually gets to be uglier and more aggressive, and so requires a treatment. And so not every what we call good risk disease stays good risk disease. So men, I think, need to, again, consult with their doctors about the merits of different choices, and then a shared decision is made. The flip side would be is in the minute you have disease that's more on the intermediate risk or the more aggressive end. Again, these are situations where it's highly curable with interventions. The odds of dying from that cancer is, by sheer comparison, say, to an aggressive lung cancer, is different. It's prostate cancer, again, is very conducive to long living, decades of living. The critical part is to pick it up earlier before it spreads, because right now, when it's spread, it is not curable. And when we talk about treatment in the majority of patients, as lifelong treatment. So the intent would be is to actually pick it up relatively early and treat, and then the options become surgery or radiation treatment. When we talk about surgery, I'm using the big umbrella. And generally speaking, most surgeons now use the robotic procedure so that there's not a big scar on the outside. It is something that I think pretty much every place is using it nowadays. And it minimizes, I would say, the morbidity. But remember one thing, that on the inside of it, the procedure is not different, is that the surgery is intending to try to remove the prostate and as many lymph nodes as possible from the pelvic region, so that will give a better idea on the cancer extent. Now, when radiation is given is different. So this is basically after a patient is diagnosed, radiation is given, generally the recommendation. And again, there is shades of gray and variation on the story, but I would say anytime you're talking about radiation, invariably it involves radiating the prostate area, which is where the cancer is, but also the pelvic region, because that is where the cancer cells can go out into the lymph nodes. And so consequently, you don't want to leave those lymph nodes behind, because obviously there could be small microscopic cancers, that cells there. And so that's done. Depending again on the grade of the cancer, if a person chose radiation, then there is addition of systemic therapy with hormone treatment. And the hormone treatment is intended to, as much as possible, cleanse the system from any cells that might have spread, but also to potentiate the effect of the radiation treatment in the pelvic region and the prostate. So these would be the two case scenarios. And then of course, there is the duration of the hormone is going to be variable depending on the risk of the disease. And this is the discussion that I think patients should have with their doctors, with their radiation oncologist. And there are national guidelines and standards that should be followed. Another thing I would recommend for patients to look at some vetted sources, and that's not generic media. What I would recommend strongly is looking at the cancer.net, which is a website patient-oriented from our society, the American Society of Clinical Oncology. And I guarantee you, having been one of the editors on that for the GU component, it is vetted, patient-friendly, patient-oriented, and centered, so that there is pure information as opposed to sort of generic recommendations that are not vetted. And if there are recommendations, these are society recommendations. So to check that in there. There are emerging data, and this is something that is being evaluated more in clinical trials, about potentially strengthening or potentiating the systemic therapy with beyond, just the conventional injections, for example, or medications to lower the testosterone level. So there is work involved in that area, also in patients who have pelvic lymph nodes by scans. So somebody comes in, they got high-risk disease, they get scans, now there's visible pelvic lymph nodes. In general, these patients are offered radiation treatment. In those settings, intensifying the hormone treatment is of value and recommended. So again, there's a lot of different case scenarios. The one thing that is clear, I would say patients should consider, if they're not comfortable with the recommendation, should seek an expert opinion, just to make sure this is not meant to be running away from your doctor, but rather a confirmation. And one thing about prostate cancer, there is wiggle room. It's not like treatment has to be like an acute leukemia, an emergency treatment. So definitely go there with it. And of course, the case scenario is different for advanced disease, and I'm happy to answer questions about that.
We also have a question from one of our guests. He asks, what is the best lifestyle to avoid prostate cancer? And specifically, is there a causal connection between artificial sweeteners and prostate cancer?
So I think this is an excellent question. And honestly, I don't know that we know clearly a risk factor that is habit-based, sort of like smoking and lung cancer, or smoking and bladder cancer, or smoking and other head and neck cancer and things like that. There is talk about it. I am not really aware of anything that is definitive. So I would not necessarily avoid it, but if you obviously feel uncomfortable, you don't have to use it. Just minimize the amount of sugar you're using.
Great. I want to move gears a little and ask, we're hearing a lot about the impact of COVID on cancer patients. And I want to put into perspective that this week, we were told that 60% of Chicagoans have received at least the first vaccine. So what are your thoughts about COVID and cancer patients? Should they be afraid to get the vaccine because they're immunocompromised, or is it a timing issue of when is the correct time for a cancer patient to get the vaccine? What are your thoughts?
Well, so Nicole, this is what I tell everybody. I got the vaccine, and I made sure that everyone in my family who were not physicians, talked to them and made sure that they were going to get the vaccine. The reality of it is, if you think about every disease we have that we have been able to prevent or reduce the risk of death, vaccination plays a huge role. And so I know that there are different concerns and fears and things like that, but I would remind everybody about starting from 50, 60 years ago, from the issues of smallpox, the polio, the HIV, and the hepatitis B vaccination. And so these are really very important vaccines, and they really protect the individual. There are guidelines, by the way, and the guidelines are with regard to, so anybody who's going to go on hormone treatment, I don't think there's any concern with, for example, getting the vaccine and the effect of the hormone treatment on that. I'm not really concerned about that. Anybody, for example, who's going to go for chemotherapy, it's a little bit different. So if there is room, for example, for my patients who we're going to plan chemotherapy for, if there is, if it's not an emergency need for the chemo, basically we're counseling them regarding the vaccination. And I will tell you that about 99.9%, I'm not calculated it by there, but I will tell you on less than a handful of men have really declined getting the vaccine. So when counseled, they have opted to take the vaccine. And I am yet to see really any major, again, in real practice, any major concerns from that perspective. There are certain guidelines with regard to men who are going to get immunocompromised about the timing of the vaccine. And again, this is where definitely consulting with their doctor about the timing and when they can get it, because we've been able to squeeze in the vaccine in between courses. And so if it's not an emergency in terms of the chemo, then there is room to do this. If there is urgent need, definitely prioritize cancer treatment first, and then figure out a window to administer the vaccine in between.
As time goes on, I don't know, maybe Dr. Platanias, you can put this into perspective. At the beginning, when the vaccine was available, Dr. Platanias, you said to us, get whatever vaccine is in front of you. There's a lot of mixed reviews about, side effects. We know more information. As, leading physicians, do you now gravitate towards one vaccine versus another?
Well, in the US, the only vaccines available are the mRNA vaccines and the Johnson & Johnson, which is adenovirus based. So the mRNA vaccines are the same, the Pfizer and the Moderna, and they are very effective, extremely good side effect profile. The J&J is also very good. There is this syndrome that has been described that it doesn't affect men usually. It's almost always, most of the cases were younger women. So I will say, yes, get the vaccine. Any vaccine is better than no vaccine. Now, if there was a young woman who had the choice between the J&J and Pfizer or Moderna, I would strongly recommend Pfizer or Moderna. And the same is true for AstraZeneca. My brother called me, he lives in Athens, and he told me, should I get the AstraZeneca? And I told him, yes, run, just go and get it now. But then a younger woman called me, and I told her, maybe wait if you can get the Pfizer, because they were going to come there soon. So it's the same story. These vaccines are very effective with minimal side effects.
Doctor, there's been a lot of literature lately, and I don't know that there's been results to studies, but suggestions that it may make sense to mix and match vaccines. In other words, take one of the mRNA vaccines and then either AstraZeneca or J&J, that has an increased impact on the immune system. And I was wondering your thoughts on that.
I don't think there is clear-cut direction for that. I will stick with the recommendations of the CDC. I think you know, the Moderna said that they may come up with a third boost dose. I think that's what is going to need to happen at some point. 6 years later, there will be a need, or once a year. I'm pretty sure this is going to end up happening. There will be a need for an extra dose. So this will be a yearly event, I think.
But I would remind everybody that's no different than the influenza vaccine, right? We all get it once a year. So
that it is much more effective. It's much better than.
Of course, no, of course. But I think as the science evolves, I think the chances of getting better vaccination is there. But I fully agree with Dr. Platanias. I think stick with one type of vaccine. I think we are fortunate in the US that we have the availability of the Pfizer and the Moderna. And same story, by the way, I have a sister who lives in England, and they were given the AZ vaccine, and then they were told, you're not going to get it in a few weeks. You go and come back in 3 months and get it. So we've been fortunate in the US to have access to the vaccines.
I got a question for this. I got a question quick.
Yeah.
For Professor Platanias, my name is Joaquin Briev. I'm faculty. I'm very honored to work in your department. Sometimes we do consults from dermatology. Matter of fact, I'm leaving. I want to do consults there right now. So I'm having a very serious problem with my immunobolus patients who share the same medication we use for B-cell lymphomas, etc. Is rituximab. So in a huge percentage of my patients on rituximab, within 9 months, the vaccine did not work. So I would like your opinion about how do you approach this issue, because it's a huge problem for us. I have a very large clinic of blistering disorder in which we use CD20 depletion in combination with other medications like mofetil and prednisone, so it becomes a big liability for my patients that the vaccine is failing. And what is the role of monoclonal anti-spike protein antibodies?
Monoclonal anti-spike what?
Protein antibodies.
Oh, the antibodies, yeah.
Yeah.
I'm not going to say that I know of the answer because I don't think it's clear. But one thing is for sure, if you have a patient who is going to get immunosuppressive treatments of any sort, you will expect that it is possible that the vaccine will not be. When you say it didn't work, was that by measuring antibodies? Or
yeah, I'm measuring everybody's antibodies 4 weeks after the last second dose, usually is the one that requires 2 doses. So I'm checking 80 to 90% if they receive rituximab within 9 months, is going to be undetectable or very low titer, very weak titers.
So you see, that's the whole thing. They need, we need to get official recommendations of how to deal with that. But it's not surprising, and it is known, and it has been described also in cancer patients.
Correct.
So I don't think anybody loses anything by getting the vaccine. I will still get the vaccine, but if we need to come up with maybe it will require to adjust. We cannot recommend that here, obviously, but the CDC or someone will need to come up with guidelines. Maybe we'll take extra doses or follow the antibodies and repeat the dose. I think that's what is going to end up being at the end.
I'm planning to write a letter with other colleagues, because what we can do is request that the people hold the maintenance therapy of rituximab for 9 months up to a year, and then we request revaccination for them.
When you say hold, I wouldn't hold the
because we normally, like pemphigus patient, pemphigoid, we do after the induction consolidation phase, we go into 1 dose a year of 1 gram of rituximab for 5 to 10 years, depending on the disease activity.
Right.
So we are holding them now. If the disease is not active, we're not giving the preventative dose, waiting for them to have the ability to respond to the vaccine when the CD20 cell become again detectable.
Yeah. So, and you don't think that compromises the pemphigus?
Not at this point. It's a
Relapse.
universal concept, because if the pemphigus is in remission, we do that. If the patient is mild to moderate, then we delay the initiation of rituximab. We use conventional therapy until they get vaccinated.
Yeah, yeah.
And then we go ahead with the anti-CD20 therapy.
Yeah, yeah. That sounds reasonable. But again, there will be a need for more detailed guidelines by the CDC at some point.
We sadly discovered the fact, somebody theorized about this last year, said if these people might not respond, and the fact is that we're checking everybody now systematically, because they're confident, they think they're immune, and it's not working for them. But thank you for your great.
Thank you. That's a great point. Yeah.
Thank you.
Joaquin, for patients who are, let's say they have follicular lymphoma and would be taking rituximab for maintenance, it sounds like you would say hold off on that, get the vaccine and let the virus pass?
No, it doesn't apply to cancer. No, it doesn't apply to cancer. Yeah. These are people who are in remission.
Yeah. I will definitely advise strongly against what you just said, Scott. I mean, the cancer treatment has the priority here, so.
Yeah, correct. Our patients are stable in remission. They have undetectable antibodies, so we can have the luxury of waiting a few more months to continue with their prophylaxis to prevent flares. But active pemphigus patient is a disease with a mortality up to 90%. We treat aggressively. We really given, that's what the role of a commercially available monoclonal anti-spike protein antibodies humanized might be important in the future. We given immunity. All right, thank you.
Can I ask, is it standard of care to check for antibodies in cancer patients after the vaccine?
Yeah, you can check that.
You check for antibodies as well. Okay.
Yeah, you can do that.
I think the question is, should it be done, Leon?
There is no standard of care, but there are many studies going on right now that we order exactly that to see what the response is. And there have been described, there are different results in some types of malignancies. So I don't think it hurts to do it. If a doctor may decide to do it, but there is no clear guideline for that now.
I guess the question is, if they're immunocompromised, are they able to mount an immune response or not?
The question is, what are you going to do different? If you give the vaccine, you give the vaccine. So whether you get the antibody or not, you will not do anything different, right? You will just continue the treatment for the cancer. And I think immunocompromised patients have to be very careful anyway. Mm-hmm. So I'm not so sure it adds much, but there is nothing wrong to order it and check it,
Yes, that makes sense.
Mm-hmm.
Can I ask, should we be concerned about the breakthrough COVID variants as more and more people are being vaccinated? What are your thoughts about that?
Absolutely. I think the concern for the breakthroughs is not here, this moment, because here there is a large number of people getting vaccinated, although it's a dangerous time because there is a significant group of people who believes the conspiracies, the anti-vax conspiracies and theories, and some TV hosts do that openly, which is terrible. But I think the biggest risk for this is what's happening in India, because in India you have right now a very large population with things completely out of control, with not enough vaccines to give. I mean, it's really a bad situation. And I believe that the Western world should have stepped in more aggressively to give more vaccines, not only for the people in India, but what is going to happen to the rest of the world. If the variants may emerge there and come back to the Western world, this can go back and forth. So I think that's probably the most dangerous situation right now. But hopefully it will not be, so bad. And the rest of the world, at least in the US, I mean, there is a very high. I think the US right now is leading in terms of vaccinations, except with smaller countries like Israel has done more. But if you go to big countries, for sure, the US is the leader now. So we'll see. But I think there is the risk with the variants is there, and it is not so much the existing variants, because those seem to respond to the vaccine. Is what else can happen with an uncontrollable situation like we see in India.
So is it possible for a variant to prevail that we're not protected from, even though we're vaccinated?
Absolutely. That's what happens with the flu. With the flu, you have variants that prevail, that don't protect. The difference is that this virus is not supposed to mutate as fast as the flu, so the chances are less, but it can totally happen, you know. So that's why it is so critical to vaccinate fast as many people as possible, you know.
Doctor, how close are we to herd immunity in the US? And can we actually achieve that factoring in all of these different variants?
That's a good question. And, you know, as you know, there is controversy at what number you get it, and this changes. But I personally don't think, if you ask my opinion, I have serious doubts that there will be ever what we call herd immunity. I don't think it's going to happen in the US. It may happen in some other countries, smaller countries, but here there is a large portion of the population that is not willing to be vaccinated, unfortunately. So they say it has to go up to 70, 80% to get around 40% right now. So we'll see if it gets there. But you know, at the end of the day, if we don't get herd immunity, still people who get the vaccine will be protected as long as no other variants emerge, you know. So I don't think it's so critical as people think it will be, you know, to have official documentation of herd immunity, as long as a large group of people gets vaccinated and protected. So,
Dr. Hussain, Dr. Platanias is a big fan of masks, and he has a lot of scientific reason to be. And he's also told us that the incidence of flu is way down, almost non-existent this year. So I'm interested in both of your views on, you know, what that tells us in terms of the future of public health. What role, you know, obviously education and hand washing and what I call anti-social distancing, but mask wearing. What role are we going to be at the point maybe next year where, like Asia, a high percentage of the population is wearing masks, even, you know, in the absence of a COVID outbreak?
Well, Dr. Platanias, you want to start?
sure. The answer is I hope so. I think that during some periods, like the flu season, it will not be a bad idea if people wear masks in planes, for instance. What's wrong with that? I think it would be a good thing. I don't think the American culture is so different than the Asian cultures that this will never happen here. But I think we may learn some lessons, like the flu. Flu kills about 40,000 people every year. These people did not die this year because of the masks, right? So I think one can learn from this and protect themselves in certain circumstances, like flying on a plane. I mean, if someone wears a mask during the flight, what's the big deal? So I think some of these things will stay, but I wouldn't expect to get to the point that we see in Asian countries because they have the culture is very different here. So
Although bowing is a good thing.
Yeah, I think maybe I should make a comment, Mr. Seaman, about it. I think that it's all about risk and benefit and personal preferences. My guess is this, is as we get, and again, this is forecasting into the future, and we don't know what the rules will be and life will be. My guess is this, is as life settles down and with more vaccinations and things calming down, my guess is that day by day we'll see lower mask rate. Having said that, it may also move into, depending on the policies, my guess is, again, we live in the US, the government cannot tell everybody what to do. And so what's going to happen is if the CDC et al. Decide mask is not a critical thing anymore, you'll find less and less people using it. There are people who are still very precautious and may choose to wear it.
I mean, the other aspect is, employers, because, one thing we have learned, unfortunately, throughout this is the ability for people to work remotely. And, we always heard a lot of during flu season is if you're sick or you feel like you're getting something, stay at home. And, of course, we cannot rely on our CDC or Dr. Fauci to promulgate great policy, but what are your
thoughts? I think clearly if you are sick, you should not be going around spreading virus. That's a fact. And certainly even when you're home, avoid contact with the family and distance and all of that, I think is going to be important. I just think that we're living in an era that is governed by two things: an acute, very distressing, disturbing situation, which is the virus, plus the media and the internet and the constant texting and WhatsApping and messaging and all of that. And unfortunately, that kind of creates chaos in my mind. And so I do think we all need to take a deep breath and chill, because we cannot be reactive to every single thing that happens every second. I think we're going to need to have sort of the visual of the whole time and then see what the evidence is and what the data is.
But one thing is for sure, this has been a devastating pandemic.
Indeed.
There are almost, what is now 600,000, we're getting close to that number dead in the US only. And and it can be prevented. When people wear masks, when both people wear masks, you don't have virus transmission. Or if you do, it's extremely low level and it doesn't cause serious disease. So I personally think that we need to follow what the current CDC says. I think they're doing a great job. And the other thing that I think should happen is that for some jobs, there should be a requirement for vaccinations. You cannot, that's my opinion, by the way, it's not Northwestern opinion, and Maha knows this, but I think people working in healthcare should be vaccinated.
I fully agree.
There shouldn't be a choice. People working in some, now if there is a reason, if there is a medical reason, or some serious philosophical objection to that, maybe they should get another, if it is a health issue, it's different. But if people philosophically don't think they should be vaccinated for some reason, maybe they are not for the healthcare job, because you expose others to risk. So I'm in favor of what they call vaccine passports, although that's an inappropriate term, because it's not a passport. That's just documentation that people were vaccinated. I think it's a very good idea. I know Scott will disagree with me, but we'll see. These are very unusual times right now, and it has been so destructive. I was talking with Nicole about a case earlier. It's so, when it happens, it's a catastrophe, and it's a preventable catastrophe. We have vaccines right now. So it's the same if we don't control it,
I know, and it's amazing. There are still people fighting for their life with COVID.
Yes, yeah.
I mean, that's what's incredible.
And no one is immune. That's the truth of it. Meaning, I had one of my gentlemen patients who came in. His daughter-in-law is a flight attendant, and she must have picked up the virus, and their 6-month-old baby got infected. Now, luckily, not severely ill or anything, but the truth of it is it's not immune, and we don't really know enough yet. So clearly, I think precaution trumps everything else.
And I'm not going to say the name, but it's someone who works in my group, in my lab, that some of you may have met, his parents are in another country, and they both got COVID recently, and they both just died. So he was like, he flew in Germany, in that country, and so terrible things happen now, right before they get the vaccine. And this is a very serious thing. But again, the good news is that we have a vaccine right now, and we have, and we know that masks work. And we will need to use less and less masks, because if you're vaccinated, this will become less and less important. But we have to remember that this is not a matter of philosophies or politics or the one or the other. This is life and death, from a terrible disease. So that's my view on that.
Agreed.
I was,
Hussain, you're in Michigan, right? Can you, what's been confusing for me is the numbers in Michigan were so high. So what's the difference between there and Illinois in terms of, because you'd think the vaccine would be just as much available in Michigan. Why were we seeing these numbers, go?
Honestly, Nicole, I don't know. And I have two siblings. My brother and my sister are physicians, and they have their own practices in the Detroit area. And on average, my brother was telling me they see easily, 5 to 7 patients who are positive a week there. Some of the areas, there were also this philosophical thing that we don't believe in what the government is saying, therefore we don't want to do this. But in reality, as a cause, is really not clear to me why they have higher rates. They seem to sort of be one of the areas, where the peak in the metro area, where the peak is really quite high. But again, I'm not really clear that we know why that is. And of course, not just only, Michigan, Metro Detroit, but other states have same trends, and it's really not clear why.
But they're improving now. The numbers are
Yes,
coming down
yes,
in Michigan.
Yes, yeah.
And that's a good thing. So,
Yeah.
And in Michigan, they have a very high vaccination rate, but the numbers were going up, and that looked very weird. But now they're coming down, and it looks like it's what you said. There were some areas that people didn't want to deal with vaccines.
Yeah.
But somehow things are getting better now. So.
Yeah. And I think what's going to be more important also is not the sort of the every 5-second changes, is looking at real trends. For example, many of my patients, just by default, they're prostate cancer patients, so they're older and they go to Florida. And literally long before what was done in, let's say, Chicago, in Florida, there was actually a pipeline of cars where people were in line going in to get vaccinated. And there's a lot of people outdoors, and there was another surge happening. So I think we all have to be careful. No one is immune to it. And the clear thing is get the vaccine, develop the immunity, but keep the precautions until we know, until we kind of have some more time and see what the trends look like. I am very hopeful, honestly, that this will become one of those sort of, chronic history type things, and certain precautions are there, sort of the story of the old days of TB, for example, the flu situation. I mean, there's a lot of diseases we went through. Dr. Platanias and I remember the days of hepatitis B. Remember, we used to draw blood ourselves for patients, and we didn't even wear gloves then. And
I was exposed. I seroconverted myself from a stick. When I was an intern, there was a patient with hepatitis, and I stuck myself, and I became, but I was fine because I didn't get the disease. I was lucky, but
the HIV situation. I mean, there's a lot of illnesses that happen. And the one thing about humanity is that humanity survived millions of years, and we can survive this. We just have to figure out how to do it rationally.
I think there's also a way that we have to get in front of this, because we all know now that we're going to have to get a booster, right? Likely. And if we, do something we can to make sure that, say, for example, the teachers get vaccinated immediately with the booster. It's got to start, I think, between the research doctors and the medical doctors to get to the cities and let them know that let's get ahead of this.
Sure.
You got to get ahead of that and get that booster to teachers right away. Because I know that Mayor Lightfoot was told in the very beginning last year, let's vaccinate the teachers first, and she didn't listen.
Yeah.
I wouldn't vaccinate a single teacher until they start opening the schools up. I'm being sarcastic, but
I know
we have to open the schools.
They have to get in front of it, Scott. Otherwise, it's going to repeat itself.
No question.
Yeah.
And one of the great things, and so Dr. Hussain doesn't think I'm completely anti-science, the ability, the fact that we have 3 vaccines available in the US and 5 or 6 throughout the globe is absolutely phenomenal. It has saved hundreds of thousands, if not millions of lives. And it's the result of good policy, but fabulous scientists.
Yes, I agree. And honestly, it's research and science that will save lives. And this is across the board. And just again, in the area we're in, obviously COVID and acuity is critical, but the truth of it is cancer continues to be there and it's not going away with the vaccine. And so I do think that this is where working together, all of us, to try to conquer cancer is so critical. We're letting people survive all of these other things, but guess what? We don't still have a single vaccine for a cancer. And I do think that working together with a team like you all and your helping us, I think we're going to come cross a huge barrier.
Well, with the force known as Eleni, we're going to do it.
Yes, and yes, we can.
We can.
I have a quick question. Is there any indication as to when there's going to be full approval of the vaccines as opposed to the conditional approvals that currently exist? Because that makes a difference in terms of employer-employee relationships and what can and cannot be compelled by an employer with regard to a healthcare employee. So do we have any indication as to when full FDA approval of the current vaccines or any of the vaccines is going to take place?
So Pfizer just announced that they're preparing data for submission to the FDA for full approval. And I have zero doubt that it will be approved because it's, the data safety look remarkably good. Again, there are some terrible things that happen occasionally, but that happens with any medication or with aspirin even, So the data are very the same. So I think it will be soon. I don't know, it may take a couple of months, but I think there will be full approval, at least of the first one, and then Moderna, I assume, will follow. So I think the biggest threat this moment for the whole story is these conspiracies, these anti-vax people, because there are people who believe them, and some of them have medical degrees, and they go around and say things. And it has nothing to do with politics. It has to do, you see them both from the right and the left. RFK Jr. is a terrible anti-vaxxer, So, and these people, I think, are very dangerous because they speak with scientific terms, and some of them are doctors, and many people believe them. So if there is a large group of patients that will not be vaccinated because of them, they could cause damage in the long run. That's I think. And there are some TV personalities who do that. I don't want to say names, but there are,
But this is what I was referring to. This whole the media, the every 5-second tweets and things like that. I think we need to kind of chill back. And I actually stopped looking at all of that stuff. I only look at our scientific journals and at anything that comes out from our societies, because there's a lot of nonsense that's going on in all of these other media situations.
It's also through the mental health industry as well. It's horrible what's going on. I have a friend that's a psychologist, and he's got a very big practice, and he was getting ready to retire before this happened. But he said generally he would have twice a week to analyze people. Now he's got 12.
Yeah, that's crazy.
It's horrible what's going on in mental, because it's everything that's on TV and it's propaganda and everything that people are saying. People are afraid, and there's too much on. You're right. It's too much on the media.
And I also think the fact that it was winter, I think as we get into the spring and summer, and as people get out and stop looking at, sort of the TV and, watch the flowers and the trees and garden and, just walk around the streets, it kind of will help the mind sort of overcome this whole, getting dark at 4 o'clock, you're sitting in your house, it's freezing cold, and you open up to the TV and there is really nothing interesting going on other than bad news.
We've all been very fortunate to have Dr.
Sorry, go ahead, Scott.
No, I was just going to say we've all been very fortunate to have you and Dr. Platanias, Dr. Hussain, and a bunch of doctors over the last 15 or so months giving us accurate, reliable information. And we're very grateful for that.
Thank you, Scott.
And support.
Thank you all.
So there's a viewer that asks, my parents are in their 80s and both vaccinated. They would like to travel to Greece for this year. And do you recommend travel to Greece after being vaccinated?
Yes, I would. I mean, as long as they're vaccinated, yes, why not? They should probably wear masks in the plane, whatever, anyway. But I think they should.
And I would say also making sure that keeping certain precautions. And I think that's going to have to continue. But as Europe opens up, which would be nice for people to travel transatlantic or wherever it is, but definitely keep the precautions.
What do you think is going to happen with the industry of the big fleets that are taking people, tourists on the ocean and everything?
I don't know. I think that they are trying to reopen. And there are some questions. Actually, I was reading about some conflict of interest of the current Surgeon General, who was getting a lot of money from that industry to advise them before. I don't know. Personally, if you ask me, I will not go right now to a cruise. But a few months from now or a year from now, yeah, maybe I would. So, but I think that's a high risk. That's much higher risk than being on a plane, because you are there for days, you serve food, all that stuff. So,
there's a small
that's
segment.
where one point, that's exactly where you have to have a vaccine passport to get in this type of thing. That's an example.
Yeah, you're right. Unfortunately or fortunately in America, there's always a small segment of people that are in the land of the free, the home of the brave, and they believe I can do whatever I want. It's a free country. And there's a small group of people that believe that. And that's the other segment we're fighting about vaccination.
Yes, that's unfortunate.
Yeah.
I want to remind everyone, it's so amazing that we have so many people on this call. I want to remind everyone that on June 6th, we have our Cancer Survivor Walk. We need everyone so much, especially after going through COVID. So please, everybody sign up on the website. We've sent out the email. You don't even have to come down to walk. You can be in your, anywhere you are, whether you're in a suburb, anything, just please help support us, make a difference to the research that Dr. Platanias and Dr. Hussain are doing. So thank you for having us, for joining us today. We will let everyone know when our next COVID talks are, but it's great to see everyone here concerned about COVID and caring about cancer patients. And thank you, Dr. Platanias and Dr. Hussain.
Thank you so much. Thank you, everyone. See you later.
Bye-bye.
All the
Bye.
mothers.
Thank you.
Bye-bye.